Well, good evening, ladies and gentlemen. It is an absolute pleasure to be here. I was trying to remember with John when I was last here. It was for some prizes, and I think they were rheumatological ones, but it's fantastic to be back. And as you see, I'm going to talk about a subject that has really become very close to my heart. It's amazing. Medicine is a wonderful thing because I specialised for so many years in a rare connective tissue disease, and then by chance I got interested in the relationship between work and health, and it has been an integral and crucial part of my life ever since, and I really care passionately about it. What I'm going to try and do this evening is to talk a little bit, first of all, about, well, is work a good thing? Is it a curse? Is it an indulgence? I'm going to go on to look at the effects of unemployment, of having no work on human beings and on their health, mental and physical. And then I'd like in the second part of the lecture to really talk about some of the work that came out of my initial review for government and a very recent review which I did with David Frost, to which the government has responded, about to roll out its response, and to talk about the things that we should be doing to make work good work and to make it possible for people to enjoy work. So is work perhaps not for a gentleman? Now, Hippocrates based his theory of medicine on the interaction between man and his environment, and yet in his writings he never talked about work, which seems just a little bit strange. Well, perhaps the Greek attitude to work was that it should be done by slaves, and he perhaps didn't think he should be doing work. And it wasn't really until the Middle Ages that doctors mentioned the health of workers in their writings, with two references to the diseases of miners, so a very long gap. Of course, by the Industrial Revolution, we were starting to come up against industrial diseases. Large numbers of people crowded into factories, and really whether the law certainly didn't appreciate the hazards, and whether the owners did or not, they certainly acted as if they didn't. Of course, when steam power came in, it could move machinery, and therefore the speed of manufacturing was increased, and work injuries became common. Long hours of work, 16 hours per day, people would get fatigued, they would make mistakes, and sickness, injury and malnutrition was very common. And therefore safety at work became crucially important. And what has been interesting as I've done this work is I've had to convince those who care about safety in the workplace that if you worry about people's health as well, they may be safer workers. But we were so keen to make sure people were not injured by machinery, by diseases that are associated with work, that in a way it became the crucial and important thing. Of course, work is changing, and we could spend a lot of time thinking about that, but just taking a very small look at it, rather continued growth at the top end in professions and managerial work, but a whole host of low-paid employment remains, and you see that in cleaning, retail, wholesaling, restaurants, and hotels. And remember that as women have come increasingly into the labour market, then often many of these jobs are done by women. More custom service jobs, far more outsourcing, less permanent jobs. Again, we have women, whether it's part-time or full-time in the workforce. The importance of homework balance, whether that's for men or women. And this concept of good work, and by good work, I don't mean whether you're well paid. I mean whether you're well treated at work. Do you have a sense of autonomy? Do you get listened to? Do you have a good line manager? It's crucially important. Is there some flexibility? Is there an opportunity for you to enhance your skills? Because goodness, we're all working longer, so we might need to have some upskilling. Transferable skills. Obviously, we have a work anywhere culture. You only have to be looking when you travel on your trains or on buses to see people working anywhere and everywhere. And then consumer expectations. So indeed, work is changing. some things for the good, some things for the bad. Well, I looked for some quotes to see whether people thought work was a benign thing, a curse, or could it indeed be an indulgence? And you can see what Sigmund Freud said. He said it gives the individual a secure place in a portion of reality in the human community. And you can see what happens to communities when there's high levels of unemployment. It usually isn't a good thing. Well, Winston Churchill thought that working hours are never long enough. Each day is a holiday. He obviously thought work really was fun and an indulgence. And ordinary holidays are begrudged. They're enforced interruptions in an absorbing vacation. Robin Louis Stevenson saying, it was very sad to see men who wanted to work, who can work, but it's not allowed to. There's no work available. And goodness knows we have seen that in our own country with the recession, and of course it's been worse in places like Greece. Roosevelt felt it was our primary task to put people to work, but no one, when you're being trained in medicine, really teaches you that work is a social determinant of health. It just isn't usually in the curriculum. The curriculum's overfull, and how do we get this in without overburdening of the curriculum? So work, well, who is it a benefit to? Is it a benefit to us who go to work? Could it have any benefit for your family? Is there any downside to children who grow up in families where their mother or father doesn't work? The employer, obviously people working well and being highly productive is a benefit to them, but a lot of presenteeism or sickness absence is certainly not a benefit. Does it benefit our government, and does it benefit society? I'll take a look at a few of these. Well, if you look at the literature, and Waddell and Burton have done a fairly good review of all the literature that brings this together, work, its value. It's generally good for health. If people are in productive and good work, then it will, on the whole, improve their health, whether it be mental or physical. Obviously provides income and material well-being. It also provides important psychosocial needs. People want to do something of intrinsic value, I think. And work is one way of being of value, of feeling that you have a place in your society. And without doubt, employment and socioeconomic status are the main drivers of social gradients in health. And Michael Marmot, of course, in all his work, has brought this out to a very, very high degree. But I do keep coming back. I hope I won't bore you by telling you that you have to be in good work. It's almost common belief in some sectors that you have to be 100% fit to work. Well, I would really like to ask how many of us in this room this evening are 100% fit. And this 100% fitness was reflected in the old medical certificate. So most GPs had the choice of saying, ticking the relevant box that said you are 100% fit or you are 100% unfit. Well, of course, that was not really helpful. And for people with chronic disease, many people with chronic diseases, whether it be rheumatoid arthritis, whether it be diabetes, whether it be multiple sclerosis, diseases they're going to have for a long time, many of them, not all, would like the opportunity to be in work for as long as possible. And I believe it is part of our responsibility to make that a possibility for any of you who have a chronic disease or have had to take time off work. This feeling of, can I get back to work? Can I feel like I'm a normal human being? People recovering from cancer or who finished their cancer therapy, we know from the work of Macmillan Cancer that many of them want to return to work, but often it isn't made easy. So it can be a good thing. It obviously needs to be done in the right way, but it can make people feel far more normal. It reduces poverty and social exclusion. And the thing you see over on the side, this advice for line managers on supporting employees with long-term medical conditions, is work I've been doing through the Public Health Responsibility Deal. I chair the Health at Work network with Earl Howe, and we have been trying to provide employers and employees with simple guides that says, well, if you have somebody with diabetes, here are some generic things you can do, and here are the people, like Diabetes UK, who will know far more about it. So the hope that we can enable people with chronic conditions to be in work. What is it that keeps us from working? Well, top of the list, and increasingly so, are common mental health problems. So it's stress, anxiety, depression, followed by, and it depends a bit on the sector, so for example, the construction sector would have more musculoskeletal problems, high prevalence, often little or no objective disease or impairment. There's symptoms. The person says, I've got low back pain. Often the episode will settle, but they may reoccur. The symptoms may persist. These are essentially whole people. They're not sick people, and we should be enabling them to be in work. Now, often underneath what's written on your medical certificate, but which is never written, no GP I know would think it appropriate to write hate line manager. Do not like the room I work in. They wouldn't write that. They have to write something medical. So managerial behavior, crucially important. They can't write, this person doesn't have good work. We've never been trained to do that. And the other thing they won't write on a note is to say, got lots of problems at home, in debt, has caring responsibilities, all the things that really you could describe as life, which comes to so many of us, if not all of us, as we go through life. So I probably would put these two almost above the one above, because so often somebody would go to work with a low back pain if only they had a good employer, if only their other problems were not actually really on top of them and they can't see their way through. So whenever you think about, is it really a medical condition, it so often isn't. So what is good work? Well, it's not sitting holding somewhere for someone to fire their rifle at in there. That's really fairly dangerous work. We would not want that. It's not, I don't think, I would be terrified if I was at the top of the skyscraper. But as you can see here, from again the work, this is mainly from the work of Michael Marmot and the Work Foundation, I just put together the things that have been listed as being good work. And I think you might be able to agree with many of those. We all want to have some control at work. We want opportunities. We want it to be stable. We'd like our employer to reintegrate us back in if we've been sick or disabled. Lots of things on that list are present in good companies and are distinctly absent where there is no good work. I thought I'd give you just one or two examples of what you might call the dehumanisation of work. This is taken from Donkin's The Future of Work. He describes Anna Sams, who wrote this, Tribulations of a Checkout Girl. And Sam reported that often she heard mothers admonishing their children as they approached her till and said, if you don't work hard at school, you'll end up like that lady at the counter. I mean, you know, to think you would sit there in your job having to listen to that. Now, actually, very often it's women who sit at those counters and not men. But work can make you sick. I think I'd be totally fed up if I had to sit and listen to that very often. You wonder what else is said as they come up to the counter. So he argued that this particular book by Anna Sampson was a wake-up call, that actually these people are living, breathing, and thinking human beings, and could we treat them as such? Slightly more seriously, there's a good article. This comes out of some Australian work and was really saying, are you better off out of work, even in our benefits system, than in a lousy job? Which is worse for your mental health and your well-being? So do the benefits of having a job depend on its psychosocial quality, which we've been discussing? Are poor quality jobs associated with better mental health than unemployment? And you can see that the study took data from over 7,000 working age respondents in a longitudinal national household panel survey in Australia, and then used appropriate models. And the results of that study showed that overall the unemployed had poorer mental health than those in jobs. I don't think that would surprise you. However, the mental health of the unemployed was comparable or superior to the mental health of those in jobs of the poorest psychosocial quality. So when we think of our work program and the effort to get people back into work who've been in our benefit system for a long time, putting them into jobs of poor psychosocial quality is not doing them a favor. And so the health benefits of becoming employed depend really on the quality of the job. And moving into a poor quality job can be detrimental to your mental health. So I think we must remember that as we think about, can we get people back into work? But what about unemployment? And again, there's a literature on unemployment that tells us that long-term unemployment can lead to poorer physical health. Often people actually really become very isolated. They often stay in their home. Their social connections narrow. They are not as mobile. It certainly leads to poorer mental health. You find that unemployed people use medical services more. There's this terrible loss of worth and self-confidence. And of course, less monetary resources. And as I'll show you, a transgenerational effect. And all are highlighted in a recession. This is just a paper that really has been looking at Greece in the recent recession. A paper written in Greece. Of course, as you know, Greece was very severely affected. Unemployment rose from 9 to 23%, GDP growth per year falling from +4 to -8%. And this really provides an important test of that relationship between these socio-economic determinants that I'd like to get into our medical curricula and well-being. So in the very top line, you're seeing here the increase in suicide rates in males less than 65 years. And here, and I was discussing this with John beforehand, interestingly, is the increase in infectious diseases and diseases of parasites. Now that is quite interesting. One wonders how many of these men are living rough. Are they getting TB? What is really happening? But you can see there the effect of the recession and also the increase in the prevalence of depression. And the other thing that was in this paper was showing us that the consultations at the public sector primary care centres increased by 22% over 1 year from 2010, and the utilisation of public inpatient services by 6%, so an increased cost on their health service. And the Greeks, who often do use private consultation, the private outpatients clinics, fell by 18%. The Ministry of Health reduced its spending. And so there was a deterioration in health services and indeed health outcomes. So again, you can see really the serious effect of recession on health and indeed to the point of suicide. I said earlier on that what is the effect on society? Well, this was an interesting article that I took from the Times. It was in May 2010. But Camilla Cavendish talked about the relationship between male joblessness, young men, and single motherhood in Liverpool. And the unemployment rate was rising, and the proportion of families headed by single parents rose from 11% to 45%. And what she said was the taxpayer has become the father. 1 in 4 UK mothers is single. These men may father these children, but she explained in this article that these women don't want them around because really they're not going to be in work. They're really not much use to them as men. So often these children were fathered by a series of men. She said the state has helped create a class of jobless serial boyfriends who prey on single mothers and on benefits. So these men need a chance, not a benefit system that undermines them. And that, of course, is going to affect society. And you can see that many of our youngsters were not in employment or training in 1997. But there are some very good news stories, and I thought I really wanted to tell you this one from John Lewis's. John Lewis opened their flagship store in Stratford, East London. It overlooked the Olympic site. They made an absolute decision to try and help unemployment in that area, and they took their partners, because they call their employees partners, 75% from local postcodes. You can see 65% of them were young, 16 to 29. And 175 of their employees were recruited from long-term unemployment. And 115 of those, these are young people, needed workplace adaptations. But what they told me, and one smiles, but it is really quite serious, their head of occupational health said, you know, Carol, they don't want to come to work for 9 o'clock. You know, it's too early. They've not been used to getting up for 9 o'clock. So coming to work on time was a real issue. The second thing was they didn't always remember they had to turn up to work looking as if they were going to meet customers. So they'd come to work in their jeans and T-shirt, you know, rather than something that John Lewis might have really wanted. But most interesting, they were tired by 2 p.m. and wanted to go home. And of course, we all laugh, but these are young people who hadn't had the chance to get used to work because they hadn't been in work from leaving school, or they may have had an odd temporary job. So they put in a work hardening program. They had a physical fitness trainer. They did daily physiotherapy, and they developed their physical fitness so they could stay at work for the full day. And they stood with it. They didn't send them away. They didn't say, go home, you're no good. We're going to take some people who are used to work. And several of these young people, they told me about a year ago, had already been identified as potential managers. So that is a good news story, but it just shows you very much that not being able to be in employment, not having the pattern of employment isn't very good for you, both your physical and mental health. And just finally in this section, if we think it affects the person who might have the job or perhaps their spouse or partner, there is evidence that children who grow up in workless families are more likely to, of course, live in poverty. They're likely to have poorer health. Child deaths from injury, there was a paper in the BMJ, correlates with low employment status and worklessness. These children are more likely to have trouble later in their lives, and they're more likely to experience worklessness themselves. So I would argue that overall, with all the caveats I've given you, being in work is better than being out of work, but there are caveats. And then we've all got to work longer. The government tell us that we really must be in work longer. The retirement age is moving, but many people want to be in work because fortunately, on the whole, we're healthier than we were before. But do remember that we need the ratio of earners and health generators to dependents, because there will always be people who can't work. There'll be children, there'll be pensioners, there will be people in employment, in education, there'll be the unemployed. We need that ratio to be high. So being healthy is a condition for work, and we want to keep people as healthy as possible so that you maximize healthy life as a proportion of our total life. I personally think that's a desirable goal both for individuals and society. But this, of course, is a challenge. Now, this is complicated. It is the journey that David Frost and I have studied in the review of sickness absence, to which the government has responded on paper and is about to respond in reality by rolling out some of our recommendations. But the only thing I really want you to know and understand is the drivers in our system, as it is at the moment, is to send you down this wretched journey to our benefit system. When you get down here, we do actually put in active support, but it's much, much, much too late. If you come right to the end that I'm particularly interested in, is what do we do to keep people in work, to stop them collecting numerous sick notes, or the new fit note as it's called, and what do we do while they're collecting their fit notes? What services are available to the GP, to the person, to enable people to move back here quickly? It's too little, too late, it's poor, it's ineffective, and it's certainly not early enough. By the time you've used up all your statutory sick pay or whatever your employer provides, and you leave work, for many people, they are moving towards our benefit system. They're waiting for the work capability assessment. Theoretically, this should only take 13 weeks, usually takes 21 plus. You've been out of work already 28 weeks collecting your statutory sick pay or occupational sick pay. You will almost have been out of work for a year before you're assessed. Every week after 6 weeks, you have less chance of going back to your own job. And after 20 weeks out of work, the stats show that you have, on the whole, less than 20% chance of returning to your own job. So this journey is crucially important, and I said in my first report, and still believe it, that the scale of the number on incapacity benefits represents a historic failure of healthcare and employment support to address the needs of our working age population. Please, can we get people coming here into work and not moving into our two big major benefit systems, job seekers allowance or incapacity benefits, or ESA as it's become. So there's a very good reason for actually wanting that. So in my first review, I did a review of the health of the working age population, told the government it was costing £100 billion a year. I thought an unsustainable burden. The health service, I think last year cost perhaps 110 billion. So very close to what it costs us to run a health service. I said it would diminish quality of life in Britain, and it would also deny business talent and the workforce. And I made some recommendations. When the new government came in, David Cameron said he wanted the reforms to speed up, so he got us to look in depth at sickness absence. He said we had to get to grips with it, and that was what we did. And I'll show you just one of the recommendations from that. But I am going to spend a few minutes on the new medical certificate, because surely many of you in the room may have collected one of these. And I said, please, can we not tell someone they're 100% fit or 100% sick? can we have a new note, and can it have a format which encourages our general practitioners to write something about the person, about whether they may be fit for work, what it would require. In broad terms, we don't want them to be occupational health physicians in this box here, and we gave them a few suggestions like a phased return to work, altered hours, amended duties, workplace adaptations. The GP could still use it as they use the old certificate. When it's used well, it's extremely good. 1 year on, 53% of the GPs said the fit note had improved advice given, and 48% said it increased frequency of advising return to work as an aid to recovery. But I always believe you should be honest about these things. It was I who suggested the note, and am I satisfied with the result? No, because in fact our GPs only utilise the maybe fit for work box maximally 20% and probably much less than that. Very difficult to collect this information because the note has been until very recently paper-based. Employers want clearer information. 77% of our GPs said they give the note for non-medical reasons, which ties in with what I said early on. 38% said the fit note had not changed their practice, and yet they are the gatekeeper to the benefit system. It is their actions that actually move you towards the benefit system. Only 23% of them said they had good knowledge of a system to which they send you. None of us would write a drug prescription lightly. Why do we write this so lightly when we're going to give you a worse, possibly a worse outcome further down the road? So it was partly because of these results that the Prime Minister said this is not good enough. And I just thought I would show you the latest assessment of use of the fit note, because there's some very good messages to us coming out of this. It was done in Liverpool, 58,000 fit notes, 49 GP practices. You can see coming through a mental health disorders. It will not surprise you that, again, it's in the most deprived areas. And that is, I think, what you would have expected, because many of these people will be in a much worse socio-economic condition than in other areas. You can see back pain was not there very much, and 22% of the notes issued for a period of 1 week, 4% for more than 13 weeks, which is a terribly long time. The 13 weeks, though, were usually for serious conditions. Men were more likely than women to be off over 13 weeks. Only 12% of fit notes advised may be fit for work. So again, that was 12%. As I say, the maximum we've seen is 20. So we do know from this work, it confirms that mental ill health is increasing, and thank goodness, fewer certificates are now issued for a duration of over 4 weeks. Mental ill health tends to get a longer duration of medical certification. So when we did our second review, this was published in November 2011, we said, well, it's not really working. What do we have to do to make it better? Advocacy by our GPs possibly helped their patients in the short term, because the person was in front of them saying, I don't want to go to work, I've got back pain, easy to write the note. But as I've showed you, probably not in the long term. Lack of appropriate intervention at a critical stage of 4 to 6 weeks. Employers felt they had no confidence in the medical certificate. And we learnt about the never going back syndrome. I never knew about the never going back syndrome. It's not a medical disease. But quite a lot of the people we interviewed who were collecting their sick note said to us, well, I would go back to work, but I am never going back to that job. I want to work, but I won't go back there, and if I go back there, I shall come out again. And we recommended in this review that a job matching service, which we'd seen work in the Netherlands, might be a good idea. And we're terribly slow, as I said, to get the right support to the right people at the right time. This is what we may get. I say may, please do not regard this as what the government is going to do, because they say they're going to publish before the end of the year, but that there will be a service at 4 weeks. So after 4 weeks of medical certification, a referral, except where there are exceptions, so cancer would be an exception, and then there would be medical exceptions, a GP would refer first of all into a service which would triage by telephone and then assess face-to-face your work-related issues, your health-related issues, and your non-work-related issues. So it would be a holistic service. It would deal with the things that aren't written on the sick note, and it would be properly case managed, and there would, we hope, be an improvement or resolution. A report would go to the GP and to your employer. But this could not work, after all David and I did, unless it's an expert service. If you like, it's a form of occupational health, but not old-fashioned occupational health. It can't be voluntary, because we failed with a voluntary fit note, really. Or at least we haven't got where we want it to do. It must be supported by an electronic fit note, not a paper-based. And that is still patchy around the country. And in the next few months, the government will tell us whether they're going to do what we recommended or whether they will do other things. But from all the work I've done, early intervention, providing expert advice, and solving people's problems, medical or otherwise, is what would, I think, get them back to work. So we will see. In the final stage, I'd just like to talk about the workplace, because I've said people leave work because they leave their line manager. They hate their work, but they would like to work. But the workplace can be a fantastic place for public health. I've never quite understood why we've delivered public health through primary care trusts or in the community alone, when about 28 million of us go to work every day, and we spend a lot of time there. I don't think there's a man in this audience that would go to their GP to find out if they're well. You wouldn't go to find out if you're in good health. You go when you're pushed, shoved, or taken there when you're sick, on the whole. I think women are a little bit better. So workplaces can ensure good work. This is in the gift of the employer. Managers could be trained and should be trained in the softer skills, and any workplace can develop a culture of health. And of course you can do this in team-based way. There's a peer support, and it's a place for communication. And now we've got Public Health England, and the health professionals in the audience will know that that is a very new body. But I was really pleased when one of their corporate priorities for this year is improving health in the workplace by encouraging employers to support their staff and those moving in and out of the workforce to lead healthier lives. And they have their delivery focused on a national standard for a workplace wellbeing charter, launching a public health responsibility deal pledge on mental health, which has now been done, and they are trying to become an exemplar employer. So I was pleased to see that. But very briefly, of increasing importance is mental health, leadership, relationship between health and well-being, engagement and productivity, chronic disease and public health. I won't read out to you the figures, but you realize from what I've said that mental health is now our really major task, not schizophrenia, not bipolar disorders, common things that we all get. And after 20 weeks of sickness absence, many, many people fall into our benefit system permanently. This is what our mental health system doesn't really do well. It doesn't help with employment issues. It doesn't partner with employers. It leaves healthcare and employment services absolutely separate. I know of no care quality indicator in mental health that asks you whether you've got back into your workplace or are you wishing and wanting to seek a job and getting help. And it leaves many healthcare professionals believing that work is neither realistic nor beneficial for people with mental ill health. That is actually what it is like and feels like. But in fact, it is improving. And I think there are signs in many ways, whether it be through the IAP services, whether it be through the public health responsibility deal, that the message is getting through. I wanted to remind you about chronic diseases again and just say the workplace needs to think about how they will reabsorb people who've had their treatment for cancer, are either in remission or indeed cured, and want to work. And Macmillan, from all their work, says that cancer patients, on the whole, want to work. But you can see the average fall in household income and how many people lose their jobs. So it isn't yet, we haven't got to a good place. And if you just think about the predicted number moving forward of cancer patients who fortunately survive and will therefore be, most of them, not all, but many, of working age, it's going to be 4 million by 2030. So many of those people want to be appropriately treated and have the opportunity to feel normal and be in work. So ignoring this sort of thing is not really very good either for society or the country moving forward. Thought I would just show you something from the NHS, because the public sector has come in for a great deal of criticism. We highlighted this in our sickness absence review, and the government responded by saying that the amount and cost of sickness absence for each public sector employer must be more transparent to the taxpayer, and that the government will work with education, health and local government to try and do this. So just going to show you what the Department of Health has produced and is now working quite closely with the NHS. These are the 5 high impact changes that they want to see in hospitals and other NHS organisations. They talk to the fact of good work, visible leadership, managerial capability, staff encouraged to take more personal responsibility, plans and accredited occupational health. This is just taken from the improved management capability. There's been a lot of good work going on in South West Yorkshire, and managers now undertake a compulsory programme. If you offer managers in the NHS a voluntary programme of training from the work of the Royal College of Physicians Audit Department, about 19% take it up. Make it compulsory, then indeed it goes up there, the things they have to do, but it is about building team resilience and increased productivity. And certainly in South West Yorkshire, they had increased engagement and uptake of opportunities. If you think engagement of staff isn't important, let me just draw your attention to this bottom one in red. NHS hospitals with high staff engagement have standardised patient mortality rates lower than hospitals with medium engagement. you're not making widgets or producing engines. You're really thinking about people and patients and their lives. So having an engaged, well staff in the NHS is crucial. And it doesn't matter where you look. Accidents will be less, and the Olympic Delivery Authority did not have one death in building the Olympic Park, which was unique in modern Olympiads. And they had a fantastic occupational health service linked in to very good general practice. So engagement is crucially important. And the work I've been trying to do with the Department of Health recently in the Public Health Responsibility Deal is about a partnership between government, business and other organisations, in which we ask organisations to pledge publicly, it goes on the Department of Health website, to support their employers, either through joining the Health at Work network. They may want to support one of these other networks, but the Health at Work network is about public health in the workplace. I have 9 pledges, and they cover, I think, most of the things that we would like people to think about or employers to think about in the workplace. We've been particularly keen to emphasize mental health in the workplace. And last week, we launched our pledge for the construction industry. And I'm going to end with that, because you might think these macho men I'd never be able to get the construction industry interested in the well-being of their workers at the sort of fluffy level. But in the Olympic Park, the men for breakfast stopped eating their butties and their fried bread and their sausages and started eating porridge and fruit after quite a lot of work with them. They are amenable to change. But just think about the construction industry, 6% of the entire UK workforce, high mortality rate. Generally, these men often give up work early, and they often have very poor health. They're itinerant, male-dominated. Most of them are not registered with the GP, the itinerant ones, and the employer can impact that health and well-being. And proactively, the big companies, the big boys, can take it down to their supply chain. So we had 200 of the big and little construction companies in Arabs last week, and they were signing up to the fact that even in the construction industry, they will start to take more care of men who often are thrown on the scrap heap in their early 50s when they can no longer do that physical job. And I think that if you can get the construction industry to start to do this, those men, when they move on to their next job, so the ones that have gone from the Olympic Park to Crossrail and they'll go on to the next thing, will hopefully have an understanding that it can be better and that they can get a better standard of health. And so they are pledging to actually do these things here. And they're a joy to work with, because now we've got them on board. They actually want to do it. They have moved on from just safety. Of course, safety is crucial, but they've moved on from that. So my final thoughts are trying to think, well, the only way to enjoy life is to work. We would all be idle if we could, is the opposite of that. And to enjoy leisure, it's absolutely necessary that it be preceded by occupation. So you can take your choice, whichever you may think. But I hope I've convinced you that good work is essential to our health. We could improve the health and well-being for many, many of the people in work, and we could reduce our sickness absence, which would benefit us all. So thank you very much.